be. And again, shaping this tooth is super simple because the diameters we're using are very narrow, so there's not a lot of shaping that is required. Hello, welcome to this week's clinical case. This is a case centering around using a smaller tapered files to shape and obturate the tooth. But before we start, what I want to ask is, one thing that always shocks me about these videos is when we look at the analytics, we can see that about 56% of the viewership who watch these videos are not subscribers. So if I could just ask a huge favour, it's a really simple and free way of supporting the channel. If you could hit that subscribe button, that would be fantastic. And I promise if you hit the subscribe button, what it does is it pushes me along, and I promise that I will make these videos more and more interactive, more and more detailed, and all I'd like to say is just thank you. So, there's a lot to say about using minimal preps for root canal, and I must admit, I hold my hands up. I found minimal preps quite difficult. So it's not so much the shaping that's the issue, but mainly the obturation. And obviously, as dentists, as root canal dentists, as endodontists, we always want to ensure that the obturation looks really nice and beautiful. So hopefully in this case, it's quite a detailed explanation of how I obturate these teeth. And also when we look at the post-op radiograph, I can show you a really interesting radiographic presentation on something that looks a bit short, but actually it is to length. So what I want to do is I want to just look at the clinical case at hand. This is a lower right 6. And we can see here that there is a less than ideal filling on the distal aspect of this tooth, and you'll see later on that it gives me a little bit of trouble. And we can see that there is quite a difficult bend, maybe, for some root canal dentists on the mesial aspect of this tooth, and the canal spaces on the x-ray also look a bit sclerosed, and there is a significant apical radiolucency. There's also sort of a question mark over the sort of status of the ID canal with this tooth, and that's obviously something that needs to take into consideration when we're doing our obturation technique. So another thing to mention with this patient is he found it really difficult to keep his mouth open, and this is a story that I tell all my patients, which is probably the nurse is sick of, is that I also found it really difficult to keep my mouth open when I had a crown done 4 or 5 years ago. So in this case, what we're going to use is we are going to use a mouth prop. And what I would say about mouth props is they are a little bit Marmite. They're a little bit 50-50. Some people absolutely love the mouth prop, some people don't, but it just gives someone just to rest their jaw on, and personally I prefer the mouth prop. You might find as well that halfway through the treatment the patient wants to take the mouth prop out, but at least you get a little bit of respite, because obviously with root canal you're going to need that space to get your hand files in, get your fast handpiece in. And in this case I am just going to remove the filling, and rightly or wrongly I start to remove the filling, and I notice that in the kind of distal aspect of this tooth there is decay, and I thought I might have got away with this, but actually really there is decay in this tooth, and the filling distally isn't great, and this just shows that humans can be fragile. They can make mistakes, and in this case what I am going to have to do is I'm going to likely just remove this rubber dam completely to complete the filling. So what I'm going to do is just going to undermine the GIC filling in this case, and then just slowly sort of move it out. Rightly or wrongly, some people might argue that I shouldn't remove the rubber dam. I should do the filling under the rubber dam, but in this case it's just just too difficult for me to place some kind of sectional matrix or sectional matrix band on this tooth with the rubber dam in place. So I made a clinical decision to remove the rubber dam and to replace the filling, and in this case what I'm going to use is just a swivel and matrix band. Once we've got the filling on and in place, we're gonna replace the rubber dam. And we can see here now that we've got a nice sort of filling in place, but the contact point is poor. The patient is going to have a crown, so this is going to alleviate this, but that's one of the problems with placing a composite filling in root canal, especially when time is limited. I've got 2 hours for this appointment, and I think the most important thing for me to do is to complete the root canal. And it's not any sort of reflection on me trying to rush things, but it's just in the patient's interest that you get this treatment done. So I understand the shortcomings of the filling that I've placed in, but given the whole situation, the patient's poor mouth opening, I felt like we had to get a filling on in this place. So the first thing we're going to do is we're going to go for some irrigation. We're going to make sure the irrigation is filling the access cavity completely, so sort of this bathtub technique. And then I am going to go straight for my working length, and I'm going to start with a mesiolingual canal, and I'm using a size 10K file to negotiate down this canal. And in fact, when we negotiate down this canal, it goes to length quite easily, so it's kind of like a kind of watch winding motion. And again, I like to push the size 10K file all the way to the 0. I like to push the hand file ever so slightly out the end, not too far, and then bring it back outwards. And as I bring it back out, and I get to the 0 reading, that's at the point where I want to sort of measure that I'm at 0. That's the most accurate way of working out your working length. And obviously I'm just going to move the rubber stopper here to a reproducible point, which is going to be the mesiolingual cusp. Some people like to just shave off the cusp completely so it's nice and flat. I think there's a strong argument for that. But in this case, I've not done that. And as I remove the size 10K file and I measure it, we can see the 0 reading is 23.5 millimeters. And again, you've seen a lot of my videos. It's the same protocol. We're going to use this 1503 high flex glide path file to 0 down the mesiolingual canal. It's going to be shaping at 23 millimeters. Again, we're going to use some irrigation. We're going to recapitulate. We're going to use a size 10K file to push to length, and we're going to make sure it's patent. And in this case, we're going to use the final shaping with a size 2004 high flex file. And you'll notice when you're using smaller diameters that it just gets the length really nice and easy, and actually the shaping is actually rather quick. Once we've shaped with our master apical file, I'm just going to again recapitulate, make sure we're nice and patent, and then I'm just going to make sure we are patent. I'm going to get back down with that master apical file, lots of irrigation, and we're finished with the mesiolingual. We're then ready to negotiate down the MB. The MB is always difficult to get down. I always struggle to get down there for some reason. The patient, this is exacerbated by the patient's poor mouth opening. And again, we're going to go straight down to length this size 10K file. We've, the negotiation of this has been relatively easy in this case. And again, I'm just going to push the hand file past the apex and then back it up, and then that's going to be our 0 reading. So we're going to just adjust the stopper and the mesiobuccal cusp. We're going to remove the hand file, and then we can see that the 0 reading is 22.5 millimeters. And then we're ready to shape. And what you need to remember is that using the bite block can make access difficult, because obviously the patient isn't going to be as wide as a hippopotamus. They're going to be biting on this block, so it's nice and comfortable for them. But the great thing about these high flex files is they can be bent into shape, so you can sort of bend them in a kind of curved nature, and then you can use that to your advantage to kind of curve it round into the MB. And again, shaping this tooth is super simple, because the diameters we're using are very narrow, so there's not a lot lot of shaping that is required. And in fact, when we come to irrigate the mesobuccal canal, we can see that both the mesobuccal and the mesolingual are confluent. So when we irrigate and aspirate, you can see that the other canal, adjacent canal, is irrigating and aspirating too. And that's really, really important to think when we're obturating our teeth. We're then ready to negotiate down the distal canal. In this case, first of all, what I'm going to use is a size 10 K file, and as I use these tweezers are great, by the way, for when the patient's got limited opening, just to sort of push the hand file in place when you're looking at with a mirror. And we hook up the apex locator onto this size 10K file, and I'm just not reaching the 0 point, and I can feel there's like a tiny little bit of a stop. Worst thing for you to do is to push this any further, or to force this too much, because you'll either ledge or break the file. Both those things are a disaster. So in this case, I know I'm not getting to 0. I'm gonna pull the size 10K file out, and then I'm just gonna use this size 20 high flex file just to open up the coronal third of this distal canal, and hopefully this is gonna make it easier for me to reach down the hand files. Again, lots of irrigation, and I'm gonna use this definder with a little bend at the end, because what you'll notice with a lot of distal canals is that there's a very, very acute bend right at the apex, and as we make a bend at the end and we just slowly wind this defined into place, you notice now that it drops into the apex, and it's ever so slightly out. So again, we're just going to very, very gently push the definder outwards, back in, outwards again. We're going to adjust the rubber stopper, and this time we're going to use one of the distal cusps, and then when we pull this definder out, we can see the working length is around 21 millimeters. And it's the same shaping protocol. Again, I need to be super mindful of this acute bend right at the end. So I'm going to use this glide path file in T mode, and this T mode is kind of like a reciprocation mode. And once we get past that sort of acute bend, you press another button and it does like a rotary motion. And again, we're going to use a succession of size 15 to size 20 high flex files, very, very gently, and we're just going to shape that apical third really, really gently so you don't cause any ledges. And then we're ready for the cone fit. What I notice here is that when I push this size 20 cone to length, it goes past the working length we found with the apex locator. So what I'm going to do here is I'm just going to crimp the point where we knew the rubber stopper was for the distal canal, and we're going to pull it out, and we're going to measure it that we're just about 0.5 millimeters away from the working length that we've worked out. Again, it might be only 0.5 millimeters, but on the x-ray it'd be a million miles out. It'd be right out the end, and it'll look awful. So what I'm doing here is I'm just using this gutter cutter just to snip the end off, to adjust the cone so it's now a size 25 diameter. We're going to just push it to length. We're going to make sure to tug back, pull it out, and we can see now that we've got the correct working length, which is 20.5, or shall we say near to that. So we know we've apically gauged the distal canal, and it's although it's been shaped to 20, it's actually 25 millimeters. And then we'll just finally fit the cone to length. I'm going to just obviously feel for that tug back, make sure where we've crimped it is fitting that kind of reproducible position, and then we're going to just snip the excess off this cone. We're ready to fit the mesolingual cone in the mesolingual canal, and as we push this to length and we feel for tug back, we can see where we've crimped it is going to that reproducible position, so we know we're at the 0 reading, and when we pull it out we can see that that's the correct length. We're going to push that mesolingual cone back into the canal, again super gently, because these cones are really thin and really small, and to sort of concertina the end of these is really easy, and one of the significant challenges of obturating. And then finally we're going to place the MB canal to length, and we notice that the MB is convalescent with the mesolingual, so we can see that it's just ever so slightly off from the 0 reading. And then we look at the cone fit radiograph, and it looks really, really nice. I suppose in a way you could argue that the mesiolingual cone is right at the end. So, there's an argument to say maybe this is out the end or not, but maybe there's a bit of inflammatory resorption that's occurred in this tooth. It's hard to say, but I'm happy with that. We are ready to do our final disinfection protocol. So we're going to use our Stylotanio disinfecting ring here. We're going to add the sodium hypochlorite to the relevant rings. And we're going to add a file to one of these hypochlorite wells to make sure when we're doing our obturation that this file we're going to use is disinfected. And then we just gently remove the GP cones. We just inspect the end to see if it is concertinaed, and we place the GP cones in the relevant wells. And this is the great thing about this disinfectant ring. It disinfects the GPs, but it also indicates which GP cone goes in which canal. And if you've got a mind like a sieve like me, then something like this is really, really useful. And then we are ready for our final disinfection protocol. We're going to use sodium hypochlorite. In this case, I use 2%, and then we're going to activate it. And then we're going to use the EDTA. We're going to irrigate the canal with the EDTA, and then we're going to activate this until it runs clear, like we did with the sodium hypochlorite. And then we're going to use the hypochlorite we used to disinfect the GP cones to finally disinfect the canals with this. And again, we're going to use our activation to make sure we activate this. We're going to then dry the canal spaces with these paper cones. These paper cones are sterile. That's really, really important. And then we're ready to do our obturation. So what I do is I like to pick the GP cone up and just dry it off. Again, I've been told using alcohol to dry off might be a bit better. And I think in my future protocols I'm going to use alcohol, and I'm going to use this one fill bioceramic sealer with these visco tips to place the bioceramic sealer to length. And I like to load the visco tip on the back of my hand, and then we under magnification, of course, I directly inject the bioceramic sealer into the canal, and then I use my hand file to the correct length for this particular canal, and then I push this file to length to make sure we've got the bioceramic all the way to the end of the canal. And then obviously we're not going to get any vapor lock. And then as we very, very, very gently push this GP cone to length, we're making sure that we're not going to sort of catch the end so it bends over and it looks terrible on the x-ray, and then obviously the tooth isn't obturated correctly. So yeah, when you're pushing these to length, you want to be really, 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 really gentle. You don't want to push it too hard. And then once you've pushed the GP cone to length, you're going to use a heated plugger just to remove the excess, and then we are going to use our Mach 2 pluggers just to condense the cones down. And don't be shy with condensing these cones. We have correctly worked out the apical diameter, so you're less likely to push these cones out if you've done that correctly. And then it's the same protocol again for the MB. Again, what I want to be sure of is that we know that the MB is confluent with the ML, because we haven't filled the MB with sealer, but once we've placed the ML cone to length, we can see that the sealer in the MB canal, and in this case, the MB canal is so filled with sealer, I am happy to not place any more sealer in place. And you can see here that the cone is completely filled, the canal space, and there's excess sealer. So we know that despite us not filling the MB canal with sealer, that it is sealed with enough bioceramic. And again, just pushing it down nice and hard. And then we're ready for our distal canal. Again, we've got to make sure with this, because there was a little bit of a discrepancy between the final shaping file and the apical diameter. And then this is kind of ribbon shaped or double canal, this distal canal. So I want to make sure there's a plenty of sealer in there to fill all those kind of spaces. And again, the same protocol, I'm using this glide path rotary file. It's been disinfected to the working length. I'm making sure that the bioceramic sealer is pushed all the way to the end. I don't want to push it down too hard, but I'm going to make sure everything's nice and to the end. And then I'm going to get my GP cone, and I'm going to very, very, very gently push it to length. And what I do like to do is some people just like to fill the canal completely with sealer and maybe put one cone in. But in this case, I feel like there's a little bit of space buccally to this canal, so I'm just going to place another GP cone in there and make sure everything's really, really nice and filled up. And why wouldn't you do that? We're using the heated plugger now just to sear off the excess, and then you're going to use the Mach 2 pluggers to condense it down. And again, don't be shy with this, because the irregular canal shape of the distal, you're going to make sure that you are condensing this GP down really fully, so you're getting all of the sealer into all the sort of anatomical spaces of this distal canal. And when we look at the X-ray, I'm really, really, really happy with this. And I suppose in a way it isn't kind of like sort of a knockout blow, and I think this is a perception issue. And I think it's because we have used these minimal tapered files. Again, you could argue that a size 2004 isn't even minimally prepped, because remember the 4% taper continues up the file, and some people would argue that the true minimal prep files are actually the ones that have a minimum diameter of 1mm, so they have a sort of variable taper where at the tip there's a little bit of taper, but it doesn't go higher than 1mm. But I think these high flex files, they've got a nice kind of way up between having just enough of a taper not to cut too much dent in. And then you look at the distal end on this tooth. I suppose if you were to glance at this, it looks like it is short of the radiographic apex, but you can see there's like a kind of bit of a sealer puff at the end of this tooth. And I suppose what's happened here, if you were to take that tooth out, you would see that the portal of exit actually probably goes in a buccal or lingual direction, and that is isn't so obvious on the X-ray, but we know that we've pushed all of the obturation material to length because we've got that nice little sealer puff. And overall, that's it. As ever, if you've got any questions or any criticisms regarding this case, if there's something you would do differently, if you see something that's not right, or you want to give us your opinion on something, please put it in the comment section below. The whole point of this channel is to learn, and I have learned so much from all of my subscribers, and I have done things, I've changed my practice based on their assertions and their opinions. So please don't be shy giving your opinions. There's no egos here. And also, if you want to support the channel, please like and subscribe. And if you want to support the channel even more, we've got a membership program. The membership program is a small monthly fee. It supports the channel, it keeps me independent, and also you get early access to content. So I'm usually working about 2 to 3 weeks ahead with all these videos. If you're a member, you get access to these videos early. And I would like to say thank you for watching, and I will see you in the next video. Bye bye.